Hello, Prasanna. Am I audible?
Yes, doctor.
Yes, yes, you are doctor.
Okay. I think there is echoing from there. Okay.
All right. Okay. Good afternoon, everybody, and good morning for our friend from Germany. Today, we are celebrating the World Neurofibromatosis Day, May 17th. Neurofibromatosis type 1 is a single gene autosomal dominant neurodevelopmental disorder with a birth incidence of 1 in 2,700. And it is because of mutations in the tumor suppressor NF1 gene leading to neurofibromin deficiency. There are lots of neurodevelopmental challenges with them. There are lots of the therapeutic intervention targets which are being explored, and recently some new interventions have been proposed. Today, we'll be having opening remarks by Mr. Prasanna Sirol, because this is being organized by the ORDI in collaboration with Association of Child Neurology India. And then will be an overview of neurofibromatosis by Dr. Lokesh Lingappa, who is President-elect of Association of Child Neurology India and in Hyderabad. Followed by neurodevelopmental issues in neurofibromatosis. I am the President of Association of Child Neurology currently. And then we have management of plexiform neurofibromas in NF1, current concepts of innovative therapies by Dr. Thorsten Rosenbaum, and who's graciously agreed to join us from Germany. Then we are going to have a panel discussion with esteemed panelists, Professor Madhulika Kabra, our head of genetics, Professor Sumesh Gupta, Dr. Sumesh Gupta is a leading dermatologist. He's faculty professor in dermatology department. And Dr. Bishrup Chakravarti, my colleague from pediatric neurology, and Dr. Rachna Sehgal, who is our alumnus and right now as professor in Safdarjung Hospital. And then we'll have some Q&A. So I would request Mr. Prasanna to kindly give opening remarks. Actually, ORDI has been working, and actually, I must say, Mr. Prasanna Sirol has made, please you come here, till you come, because we are already running late because of some logistic issues. So we will, besides being a parent, he has spearheaded such a major organization, and he's made a mission in life to help everybody and each and every rare disease, not only the rare disease which brought him into this area, but he's helping each and everyone. And I think he's been a one-man army. And salute to Mr. Prasanna for all the effort he's doing. And he's well-renowned globally, Mr. Prasanna.
Good afternoon, everybody, and good morning. Thank you, Dr. Shefali, for that introduction. I am Prasanna Sirol, co-founder and executive director ORDI. I would like to take through a brief about me and our organization ORDI. Why I'm doing this, as Dr. Shefali said, my own story where my daughter was one of the first Pompe patient diagnosed in India way back in 2007. And my journey in diagnostic odyssey in managing her in last 24 years, then the challenges in getting the costly medicine, then successful in getting the medicine through a charitable access program, and then managing her socialization, getting her to school, facing the challenges of inclusivity, and then managing her at home under the ICU because she went on ventilator. Since 2007, she was on a BiPAP, started going to school and college with 2 machines, and then also managing the core morbidities in terms of immunosuppression therapy, scoliosis, etc. All this entire journey taught me and made me to think something, because when she was diagnosed in 2007, and when she was born in 1999, and immediately after 6 months, when the symptoms started showing, there was everywhere, darkness. I mean, the lack of medical fraternity, awareness among them, then going to different hospitals across India for diagnosis, etc. Everywhere there was a negativity saying this is a genetic disease, nothing can be done, there is no medicine, etc. Finally managed to get her through degree. Then when she was doing her first year in degree college, the ventilator switched off, and last 5 years she's in semi-coma stage at home. I think this is the background where we started our journey to bring some changes and solace to the rare disease patients in India. That's how ORD has come into picture in 2014 after my initial stint with forming a lysosomal storage support society. ORD started in 2014 with a simple vision to make the life of people with rare diseases better than what is they are facing, and also at the same time to bring the collective voice of all the rare disease patients and stakeholders together, and then the rare disease patient also should have access to the same resources what a normal child has in India at least. When we started working, we work in the we are the only organization working on 360-degree on rare disease management, right from advocacy, awareness, treatment, patient support, clinical trials, and also, access to clinical trials and encouraging the companies to come to India, R&D, then working with the patient advocacy groups. We also work with more than 20-25 patient advocacy groups, that is individual disease specific. And we are also a member in across global international organizations so that the good practices can be brought here and implemented without much delay. And now also working on the future in terms of rehabilitation, end of life care, which is the long-term dream of this organization. When it comes to patient support, we have started the India's first rare disease helpline, which is running from 2014 onwards. Then we have recently initiated the crowdfunding platform Save My Life, so that the smaller cost also can be raised, which the current existing commercial companies are not encouraging. And we also started Inclusive Pharma, which is to support long-term medication to the parent at a discounted price, which will at least bring certain reduction in the cost. When it comes to treatment, initially Karnataka was one of the first state to start reimbursement of LSD treatment, and we have an exclusive daycare ward started in Indira Gandhi Institute of Child Health, which is now more than 80 patients take ERT in this, and this is one of the biggest center across Asia. And when it comes to awareness, one of our major is Race for 7, because we wanted to bring the change awareness among the general public and other stakeholders like media, public, policymakers. This is one of our successful program which is conducted on occasion of the World Rare Disease Day in the month of February. From last 7 years, we conducted, and this year in 2023, we conducted the 8th edition of it in 13 cities, including AIIMS New Delhi. And we are also able to associate and conduct in different hospitals like AIIMS, Center of CHG, CDFD, SGPJ, Lucknow, etc. And these are the few photographs where general public and celebrities come. And these are the celebrities across India, local, who have supported our event and participated and helped us to take our voice, including Dr. S.V. Balasubramanian. When it comes to track record and the impact, I think there are many. First is we have received more than 12,000 calls to our rare disease helpline, including the doctors. Today, sometimes the doctor calls up and says, I'm diagnosed the patient with this. What is the next process? Where is the drug available? Is it a clinical trial, etc.? And we are associated with more than 8,250. That means supported the patients, and we conduct various webinars like this and ensure that every disease gets the due respect, and people are aware about this, and there is a focus from the medical fraternity. And these are some of the photographs which we started way back in 2014 in Karnataka. All the patients came together, and the court case was filed on behalf of LSDSS, and that is where the treatment started in India, when everybody was saying that in India it is not possible to treat such a costly conditions. And these are the few photographs of the exclusive daycare ward. And this is set up in the government hospital, looks exactly like a private, and children are happy about it because they have to come every week, fortnightly to the center. And then we also run few specific clinics like SMA, DMD thing. And these are the photographs which we conducted in Baptist Hospital in India, in Bangalore. So what that every rare disease need to be fight, because that's why rare disease called, because there are few numbers and their support system is very little, or it's fragmented, or it's very difficult to find out from any newly diagnosed patient or an undiagnosed patient. So there is a need that every stakeholder has to come together and work together. And in the endeavor of this, based on various work which you have done, I'm proudly, I can say that we are a change maker in this country to bring the discussion of the rare disease from 4 walls to the public domain. and we keep looking at new conditions, so that once the new condition is get recognized and there is a patient, then there's a drug, then the company, then the ecosystem start building around that, and over a period of time the patients start taking their own challenge. That means we need to keep repeating this exercise with everything. So today we are happy to bring awareness and another disease to the front runner in India, neurofibromatosis. And today is the World NF Day, and we thought it's a perfect occasion to start awareness on this in this country. And this is the first event in India to start. And today we are all here to observe NF Awareness Day. And I take the opportunity to thank everyone who have joined offline and online to make this event a successful. And I'm sure in days to come, there is an ecosystem built, the support from the medical fraternities, support from the public media, so that NF patients also get the same support what they have been getting worldwide, or in future when the drug comes, they get immediately access to this and their life changes, or at least it makes their life better. So as we said, we all need to be the change maker, and we want to see that we wish that there is a change in India also. Having said this, I request Dr. Shefali Madam to take forward this program. Thank you so much.
Thank you, Mr. Prasanna. Dr. Lokesh?
Yeah, Dr. Shefali.
Yeah. Thank you so much. And sorry for having to wait for 15
No,
minutes.
no, absolutely not at all in this shift.
So, Dr. Lokesh Lingappa, as I mentioned, he's a very well-renowned pediatric neurologist, not only in India, but globally, but he's in Rainbow Children's Hospital, Hyderabad, and he has his outreach OPDs, I don't know, across all over India, probably. And, and he's a president-elect for AOCN. He'll be talking about overview of neurofibromatosis, and over to you, Dr. Lokesh.
Yeah, thank you. Thank you, Dr. Shefali, Dr. Prasanna, for starting such a good initiative in the country. And it requires support from all corners, including government, the NGOs, and there are a lot of stakeholders who should come together, not just for NF, most of the rare diseases in general. I'll quickly go through the disease background. I think many of the clinicians are aware, and if there are parents or the patients who are there in the audience, I will just quickly go through the disease background and biology, diagnosis, and in brief about clinical features and symptoms. I'm not going to touch much on the approaches and current therapeutic options. And as we know, neurofibromatosis, there are 3 types. We are going to talk of NF1 here today, which is the most common type, which accounts for around 96% of all types of fibromatosis. And so it is quite common. It affects almost 1 in 3,000 people. And ethnicity and gender have no effect on the incidence of NF1. And it across the world, it's almost similar incidence what we have found with this condition. And what is NF1 gene codes for a tumor suppressor gene called neurofibromin. And it is located on chromosome 7, and it is causes a lot of germline mutations are seen, and almost 2,800 germline mutations have been found. And it is one of the highest rate of germ cell mutation is seen with for NF1. It is almost 1 in 10,000 gametes, which is almost 10-fold higher than seen in most of the other inherited disorders. And how does this cause the problems? And neurofibromin is a gene. When it is functional, it causes down regulation of cell proliferation, whereas when it is defective, causes activation and excessive stimulation of cell proliferation pathways, predominantly in the neural pathways, also to abnormality in the bone and the growth as well. So it acts through the RAS pathway, which is RAS and RAF pathway, which are in its inactive form. Neurofibromin regulates the activity of this pathway, resulting in reduced cell proliferation. So actually what it does is when the RAS and GTP stimulate the cell pathways, which in the RAF, MEK and DRK, which are all associated with cell proliferation and survival. Whereas when neurofibromin, what it does is it inactivates the RAS by conversion of the active form of RAS GTP complex into inactive form bound by GDP. So that way it will reduce the amount of cell proliferation and cell survival. So that is how, if there is dysfunction, this pathway is activated and there is excessive cell proliferation. Understanding the pathobiology of any disease is extremely important because that's where the treatment comes from. So through this role, neurofibromin suppresses activation of downstream effectors of RAS, including MEK. So clinically, how are we going to diagnose? I think it's very clear for most of the clinicians. So we, as a clinician, some of the time the parents come with, okay, if the child has multiple Kefauver spots, is it NF1? This is a common scenario we see as a pediatric neurologist. So the diagnostic criteria as of now is if it is met in NF1, if there are 2 or more of the following criteria are met. So Kefauver spots in prepubertal children, it should be more than 0.5 centimeter, 6 of them or more. In adults, it should be more than 1.5 centimeter, 6 or more. And neurofibromos, if I have at least 2 or more neurofibromos, or 1 or more plexiform neurofibroma. So if you have 2 of this, you will have a confirmed diagnosis of NF1. Axillary freckling or inguinal freckling, optic pathway gliomas, which very commonly we see in infantile age group with visual impairment, hydrocephalus, and multiple complications. And Lisch nodules or choroidal abnormalities are commonly seen, as it is more easily documented in older adults. And distinctive osseous lesions, which are very common, is either sphenoid wing dysplasia or anterolateral bowing of tibias, or even pseudoarthrosis of long bones. So any of these 2, or if you have one of them and you have a confirmed heterozygous pathogenic NF1 variant seen, that is also quite characteristic to say, yes, it is NF1. Or if you have an adult who has already diagnosed and the child also has one of the criteria, then you have NF1. So I think all of us are aware of Kefauver spots. I'm not going to spend too much time on that. And neurofibromas are generally benign tumors that develop along the nerve sheaths. They can be quite extensive, and the plexiform neurofibromas affect almost 30 to 50% of patients with NF1, and they are quite varied in size. They can be under the skin or in the superficial layers as well, and they can be causing local discomfort, nerve abnormalities, functional abnormalities, and cosmetic abnormalities significantly. And axillary fracklings are one of these criteria, which usually commonly check in any of these children or adults when there is a differential of NF1 considered. Lisch nodules is quite well seen in hypopigmented iris, but in brown-eyed people, it's usually seen as hypopigmented spots, and it's present in almost 90% of adults if you check carefully. And as already mentioned, optic pathway gliomas, they come with usually in infancy, and very indolent, very slow growing tumors. Complete resection is never possible, and they lead on to a lot of hydrocephalus, extraxial fluid collections, and very slow debilitating course in many of these children. And the bone abnormalities, the long bone bowing can be seen. So you need to carefully look at the long bones, and also you'll have to measure the growth, because spine growth can also be affected, and they can have short stature as part of it, and you can have sphenoid wing dysplasias as well. And the pathogenic variants may be located at any point of the gene, because if you have 2,800 variants, so 90% of these variants are well characterized, and you can your genetic testing has a very good yield for the NF1. But I think the clinical criteria are what we mostly use, and if you have to do antenatal, then we are going to go for the genetic testing. Okay. So I think these are the things which we have already covered. The clinical features, which includes visual impairment, optic pathway glioma, speech impair, they can have cognitive impairment. It's in a small percentage of patients who have intellectual delay. And the skin we have already discussed. They can have short stature. That's why yearly monitoring for the stature and scoliosis is extremely important in these children. And the digestive tract abnormalities, they can have chronic constipation or sometimes diarrhea. And other neurological symptoms like epilepsy, they are prone to moya disease with stroke, but that is in a very small percentage of patients, less than 5% might have features of moya. And learning disabilities, as already mentioned, and macrocephaly. Hypertension is one of the problems that can be seen in these children, and early or delayed puberty can also be seen. And I will skip these things, and because Dr. Shefali is going to discuss in detail about the neurodevelopmental aspects of neurofibromatosis. Thank you. Dr. Shefali.
Thank you so much, Mukesh, for a very wonderful overview. Yeah, I will take over as the neurodevelopmental issues because that's very close to my heart. And yes, you do have some specific neurodevelopmental issues in neurofibromatosis, which we don't commonly read or look for in the patients coming in the outpatients unless they're directly coming to us for those issues. Can I have the slides? Just a second, I'll just take the slide. Okay. Okay, so neurodevelopmental disorders. NF. This you already know. Single gene autosomal dominant disorder. So regarding neurodevelopmental disorders, the burden of the ID is more. Estimates of ID have varied, but they are more than that in the general population. And there are impairments in attention, executive function, language, and visual spatial perception. And those children who have some oncological complications like optic nerve gliomas and schwannomas are at higher risk for cognitive and behavioral sequelae associated with the cranial irradiation and chemotherapy as well, which is there. This is the spectrum of neurodevelopmental disorders in NF, was a good article which was there in 2020. There is impairment in, there may be impairment in ID and intellectual ability, that is ID you may have. They may have executive function deficits. You may have visual spatial impairment. Attention deficit hyperactive disorder has been seen in as many as 38 to 67% of the cases. And they're very important to see that we have to proactively look for them. Learning disabilities with impairment in specific academic domains of reading, spelling, and mathematics is seen in as many as 19 to 61% of children patients with the NF1. This was a study done in youth, so that's why it's written youth with NF1. And the language disabilities were in up to 50% of cases. Very interestingly, difficulties in social functioning and autism spectrum disorder has been reported between 10 to 39.2% of cases, and motor coordination disorder has also been reported as well. As there is this, what is the pathophysiology of NDD in neurofibromatosis? There is dysregulation of RAS and MAPK pathway, which causes altered GABAergic neurotransmission, both in the hippocampus and the cortex, which results in deficits in spastic plasticity and learning. And GABAergic inhibition is important for the stability of neural networks. And that is why it is very important, and increased GABAergic activity disrupts the plasticity during critical times of periods of brain growth. So in NF1, mice have shown there is enhanced extracellular regulated kinase and GABA activity in presynaptic neurons, hippocampal neurons with deficits in long-term potentiation, hippocampal plasticity, and spatial learning. So decreased, RAS pharmacologically with GABA receptor blockers have been shown to improve memory, learning, and attention. So the imbalance between glutamatergic and GABAergic processes, among others affected pathways, may explain the altered neural activity and cognition and behavioral challenges. What we see in autism and ADHD associated can be understood. There are associated impairments in adaptive functioning along with intellectual disabilities, and in the estimates have shown to be having ID in 4 to 8% compared to 3% as in general population. And reduction in IQ is by approximately 1 standard deviation related to both the general population and unaffected siblings. And in individuals with 17q, 11.2, 1.4 megabase NF1 microdeletion syndrome, over half have IQ less than 70. So this is the part, this particular deletion syndrome, microdeletion syndrome will have less IQ. And they also nearly have, all of them will have, coarse facies or hyperterrorism. NF1 clinical severity generally is not a reliable predictor of intellectual disability, except what we mentioned about the 17q, 11.2, 1.2 megabase microdeletion. And impairments exist even when the children with intracranial lesions have been excluded from the analysis. So it is not necessary that you have an intracranial lesion to have a cognitive impairment. They, coming to the executive function, they are deficits of executive function, primarily mediated by the prefrontal cortex. The frontoparietal and frontostriatal and ventral attention networks are implicated in the neural pathways mediating the executive function networks in NF1. And executive functions are compromised in the working memory capacity, inhibition, and cognitive flexibility. And deficits in working memory and planning and problem solving are in the moderate range, whereas deficits in inhibitory control and cognitive flexibility are slightly smaller. Those with NF1 as well as an optic nerve glioma or any other CNS tumors have more executive function problems. A recent meta-analysis published in 2020 has shown that verbal and visual spatial working memory are both negatively affected by NF1, but verbal memory is relatively more affected. So there is basically a hypoactivation in the frontoparietal and frontostriatal networks, and reduced functional connectivity in the left DLP-FC and right parietal cortex, and increased activation in the posterior cingulate cortex and temporal regions. And a pilot study had found that youth with NF1 demonstrated improved performance on tasks related to attention and spatial working memory following 6 to 10 weeks of COGMED, which was a cognitive training program. So there was another paper in which there was studied about functional MRI of visual spatial processing in NF1, and both verbal and non-verbal cognitive deficits were seen as common in children and adolescents with NF1, but visual and spatial impairment was the hallmark of the disorder. And these findings had, what they found was they have some frontal cortical anomalies in NF1 which were seen. The meta-analysis also indicates that NF1 have small but significant reduction in inhibitory control, and they have inhibitory control deficits were found all those who had ADHD as well as those who did not have ADHD. And there was decreased white matter integrity, there was elevated medial frontal GABA and hyperfunctioning of the mesolimbic dopaminergic pathways. In youth with NF1, cognitive flexibility skills were lower as compared to controls. Planning and problems solving skills were also lower, and difficulty in motor planning and motor coordination was also less. ADHD is a very important chunk of neurodevelopmental disorders, have been shown to be as many as 38 to 67% of NF1 have been found to have ADHD. Presence of ADHD has been found to be a major risk factor for poor social functioning and poor school performance, as well as poor general intellectual functioning. Children with NF1 with concomitant diagnosis of ADHD have significant deficits in visual and verbal working memory. Generally, we have in them, we see more of inattentive type of ADHD or combined type of ADHD. Hyperactive impulsive type is less commonly seen. SLD also is common. Higher incidence of reading disability has been seen in NF1 compared with the non-effective SIBs, and they have more global language impairments. And in one of the studies, the UBOs, the hyperintensities in the brain or MRI were found to be associated with language-related learning disabilities, but this is controversial because some studies have found and some have not, as will be clearer in the next 1 or 2 slides. And they also found that children with NF1 who had macrocephaly had significantly lower vocabulary scores than those without macrocephaly. Another interesting thing was when they, in this study, they had followed up and they had seen the early development trajectories in infants with NF1. And they found they recruited the NF1 and low risk controls at 5 months. And they followed them up at 5, 10, and 14 months. They found that overall cognitive and behavioral trajectories of NF1 group in the infancy was similar to controls. So the problems come up later. So that is something which is important, and early intervention may be helpful. Coming to NF1, yes, UBO, which I was mentioned, increased total blood brain volume, increase in corpus callosal volume, and hypertrophy in subcortical structures as thalamus and putamen and cerebellum have been seen. There has been shown that increase in the volume of the corpus callosum has been shown to be inversely proportional to verbal and non-verbal intelligence and to the severity of ADHD symptomatology. Regarding the total brain volume, it's not very clear. The UBAOs are now basically being mentioned about it earlier, which was unidentified bright objects, but now the current term is focal abnormal signal intensities, and most frequently located in the cerebellum, brainstem, and basal ganglia, as you can see in this picture with the red arrows. The highest lesion burden is detected in early childhood, and the fastest decline is observed in thalami and cerebellum, and hemispheric and the deep focal abnormal signal intensities tend to decrease in number with age, whereas diffuse lesions seem to be more stable. From a prognostic point of view, they are benign lesions, and recent studies have concluded that they do not predict any executive dysfunction in children. So it was initially reported, but it is not so believed now. So they have been conflicting reports. The volume, structure, and functional connectivity changes are more pronounced in younger patients, and they have global increase in brain volume, and particularly of the corpus callosum. Now, coming to a very important domain of it is autism and neurofibromatosis. Autism general prevalence in the population is reported to be 1%, although CDC US current figures as of 24th March 2023 is 1 in 34. The centric study of autism, which was done, in which I was the network coordinator and the site lead, was the INCLIN study in the age group of 2 to 9 years. And we found an overall prevalence of 1 in 89, but mind you, the data was collected in 2011. In the age group of 6 to 9 years, it was 1.4%. And there is a high familial recurrence risk, and monozygotic twin concordance rates are approaching around 90%. Genetics of ASD, actually ASD is very interesting. You have genetic predisposition, you have environmental factors affecting the gene expression, which are the epigenetic factors. And according to me, which I firmly believe that this is the domain where we can act and get more therapeutic intervention targets. So that is something important to understand the epigenetics. Regarding genetics, ASD is a complex disease of complex interaction between genetics, environmental, and obviously environmental affecting the gene expression, with heritability estimates of 40 to 80%. And genetic heterogeneity with hundreds of genes have been linked to autism. But the monogenic causes are Rett syndrome, Fragile X, tuberous sclerosis, NF1. Genes involved in protein synthesis for neuronal synapse like synaptic vesicle cycling protein and SCN2A and KCNQ3 and all have been implicated in ASD. Coming to autism in NF1, it has got a high autism prevalence. NF1 is a good genetic model for understanding the neurobiological mechanism of autism. And literature has indicated an elevated autistic trait burden in NF, especially type 1. Recent meta-analysis demonstrated a large effect size of 0.91 of autistic behaviors in parent-rated trait questionnaires. Despite evidence that NF1 is associated with autism, still active debate is there regarding various neurodevelopmental disorders, and ADHD, SLD, and autism are the commonest which are there. When you see by established diagnostic instruments, the autism prevalence has been seen in 11 to 26%. So understanding the autistic phenotype in NF sets the goal of establishing genotype-phenotype relationship, thereby precision medicine can be employed for treatment. As is already mentioned by Dr. Lokesh, and that NF1 codes for neurofibromin, and that helps in signal transduction. And in the animal with NF1 knockout, there is an excessive RAS activity, and increased GABAergic activity causes cognitive deficits. So there is impaired myelination, neurotransmitter imbalance, and impaired long-term potentiation. Is RAS pathway linked with autism? There is no definite evidence about it, but yes, certain gene disorders have been single gene disorders like Fragile X, TS, and have been seen to, one has been studying about it, and they have some copy number variation which predispose to autism, which harbor genes that influence the RAS-dependent signaling. In the Drosophila model was used to study mechanisms of the core symptoms of autism for NF1. The loss of function of larval NF1 resulted in tactile hypersensitivity, which parallels the sensory issues of autism. And the mutant larvae exhibited the synaptic transmission deficits at the glutamatergic NMJ neuromuscle junction with increased spontaneous but reduced evoked responses. This could explain the hyperactive symptoms in autism. So this was a very interesting study which was done to delineate the autism phenotype in children with the NF1. Children meeting the diagnostic criteria, as mentioned by Dr. Lokesh, was 154. Then children who were scored in clinical range in the social responsive scales with a T-score of more than 60 were 77. That means 77 out of 154. And then when they did a detailed evaluation by the ADI or ADOS2, they found 41. That means 53% met the cutoff. So this is 53% of those who had social responsive scale positive, but overall it becomes 41 out of 154. That is 26% of the NF1 had autism spectrum disorder. This was a very interesting study, and studies improve. Whereas in the general population, the way data has been showing varying between 1 to 4%. There have been various models which have been developed to understand how this autism is developing. So there is a socio-cognitive integration abilities model, which is there, which is a recent conceptual framework that accounts for the dynamic interaction between the biopsychosocial constructs in the conceptualization of social development, which involves the complex social brain network of the fusiform gyrus, amygdala, and orbitofrontal cortex, which are vulnerable to developmental disruptions. So they have been seen in Fragile X, TS, as well as NF1. So when you compare the autism NF versus idiopathic, the children with the NF1 appear to demonstrate fewer repetitive behaviors and better language skills than idiopathic autism. And children with NF1 revealed intelligence estimates with an average range compared versus low IQ, which was seen in the idiopathic autism. Also, the strong male to female bias of 4.5:1, which is seen in idiopathic autism, gets attenuated to 1.6 to 2.6:1 in NF1. And the average age of diagnosis of autism in NF is also grossly delayed to beyond 10 years. And obviously, having a ADHD along it was going to be a confounding factor. And the restricted and repetitive behaviors were less frequently seen, and they were the most common restricted repetitive behavior was insistent on the sameness. Possibly this is because of their good IQ in these children. So there can be a pharmacological intervention targets for this mTORC1. So this is mammalian target of rapamycin complex 1 related ASD, and mTOR inhibitors have been shown, like when sirolimus was studied in TS for renal angiomyolipomas as well as lymphangiomatosis, they found that the recall memory, executive functions improved, as well as everolimus has shown seizure frequency to be reduced and behavior to be improved. So there are many, there are several of the genes in the signaling pathway that are associated with ASD. Of note are the one of the TSC, Fragile X, microcephaly, autism syndrome by PTEN and NF1. So basically now we have so many options which are there. This will be the precision medicine, which will come up, the mTOR, the NMDA, GSQ, 5-HT, and IGF-1, and oxytocin. So all of them can be a possible intervention targets with future precision medicine related therapies for autism spectrum disorder. So everybody is a genius, but if you judge a fish by its ability to climb a tree, it will live its whole life believing that it's stupid. That means everybody is different. And in NF, you have so many problems which are there in these children who have relatively preserved IQ. We have to understand and see everybody what the issues are, holistically evaluate the child, and then have expectations based on what they have. And yes, as I mentioned to you, that in the first year in the infancy, all the development was going along with the control. Things are happening later. So obviously, if you have an early intervention program, then you are going to have a better outcome in these children. Thank you so much. And when the world says give up, hope whispers, try it one more time. And we are all there to see, and we have to ensure that we see every child holistically, because they have so many comorbidities, so that we able to have, and the child reaches his maximum potential. Thank you. I would Dr. Thorsten, are you there online? Dr. Thorsten Rosenbaum? Dr. Thorsten Rosenbaum, sir, you, yeah, please, yeah. So, so he's from Clinic of Professor D. Thorsten Rosenbaum, professor from the Clinic of Pediatrics and Adolescent Medicine, Neuropediatrics, Germany. His special research focus on neurocutaneous syndromes and tuberous sclerosis. Has published numerous articles in the field of adolescent and pediatric neurology. And anybody working in the field of all these neuroectodermatosis know the name and the authority. Thank you, Dr. Rosenbaum, for having joined. And I would request you to deliver your talk on management of plexiform neurofibromas in NF1 with the current concepts and the innovative therapies which are there. I know there's some trial going to start because somebody did ask for a feasibility in the number of patients we have. So I understand it's already in trial mode and many more must be in the pipeline. Over to you, Dr. Rosenbaum. Dr. Rosenbaum, we could not hear you, although we could see you and your slide. I think they're just settling the issue. Hello? Yeah, we can hear you now. That's good. Thanks. Yeah, do whatever you've done. You don't change anything now. Yeah, thanks. Yeah, you can start off again. Yeah.
If you look at clinical setup, then you will find that the neurodegenerative of and if you want whole body we will find flexible neurodegenerative in clinical setup. And all the genetics, because we are not bothered to our heart, and I would say that in most cases, it's not better to be able to allow the development of the data and on, but it's what they are available. In most cases, the first manifestation of one. And these calculations are made by strengthening, which is something like a initial form of calculations in the acceleration of the ones, then the diagnosis of one can be sent. So the calculations and the fragment is better the first implemented than the second. Then on and that is like here that originally happened to find on APA or the business was but basically the what we are having to say on the details we don't have to. And diagnosis and what as we are found can be established two of these other constitutions to do. And this is the case in the vast majority of patients by age 6. So in order for them to do things not home to get straight off from solve it can be a challenge to this one thing which is necessary to be pointed is that not all patients of anything are months, but they will evolve with time. So the picture of the disease in the body can be completely different from the picture of the disease, for instance, in infants or in child. You see that in serious problems are but this negative consequences don't For instance, let's say my overall start with the same all and so on. So, what is the overall? First of all, is to say that the overall is outside. For instance, Dr. Smith, he wanted the 1849 on the 40 and list. He was on the post. And then also the same German project on the printing house that was for writing all of these. He established that with around 5 post of the week that at least the position the majority of these are concepts. He also tried to show that these things are set as present in the law. One of the matter is that he also has one of this concepts. It's like the second only the concept in the single show and the concept may not see the same concept in those fields, but also they have the result of this. And it's that we complete that answer the property and we repeat from the property. And that's where our book many 22 years ago. And we first tried to grow huge concepts in the country, which can see from the top side to the right. These are huge concepts from the normal to 20%. And you can see the typical from the consolidate that is very limited for the orientation from both sides, and these are our live kind of effect. The next volume, I'm running from the field of the house ones that you can see, of course, that these from different concepts. They don't have these very long processes that only normally create and also as one content division and grow to this format. So transfer made the wrong and cumulative really for this that all concepts are transmitted and not included, not fabulous together so that having the words. And the next thing that the concepts are all this is the other one, probably then the rest of the body, one and two different types of neurons. And the reason for that is that concepts evolve along very long time for feedback status. And if the somatic adaptation hits and the donor pure concept, then the one will rise. Obviously, this shadow must be permits an embryonic process only restituting and one of the other. So for this process, is by sand and one day, that affects the aroma of the rabbits. And this type of affecting the aroma has prevented the person can not rise later in the life when these embryonic concepts do not exist. So in this cartoon, you can see the difference between the dog with raw left side and the best one with raw. One reason understand to be small and they obviously appear at the side of the skin and also curl out the fuse. For me, that's the only minority of my kids already have on the ones. Correct. I can get the last time to be that as said before. And the it's typically always within the body. They have access to 40 to 50% of patients and they really control the north side. And then the problem for patients. And in contrast to developing your programs, platform your programs and the risk to progressively exceeding or 10 to 50%. So here you can see different pictures of platform your programs in different parts of the body, and as you can imagine, for instance, if you look at the patient, they will have a multiple platform your programs. They have to be disfigured and only deficits and all these factors in the programs significantly contribute to the development. So what do we do? Under risk, we do for research. So I think research all these programs. And the thing is, if it is possible, then the programs start. So we have to be success, and it's the only cure reality. The paper actually is not feasible in most cases, or has low risk, but also not and it might be a really important super. So all of it is limited to the field of people and just. And since that about affecting the device cannot be removed completely because of the risk of possibility damage. And if you look here at the customer belongs to the base or at the neck, in this case, these actually belongs cannot be receptive without that. So obviously there are companies for not software that are these customer belongs. And the first thing that something not software that would be not realized. And 10 years ago, from Henry students, this is not by intellectual students now. If you could cover that negative, humors in one of mice could be shrink considerably up to 8%. And this then was applied in a human setting, so we studied in the national studies. They showed that if of course the method is used, then you have similar reduction of reduction in size in respect to the device. If this patient here, the patient has a big factor of one device, and for the cost, you see a considerable size in reduction of the tumor as from the then by the device. So, what are we we are first landing about the machine problem that we have country is negative level of the last. That means that we are going to this the population of drugs to in and the products. So this is not only this question with the woman as the quality and the then the thing is not pressed and it's completed to these different movies that's located different attached to the lupus then might lead to motivated disability. Also like the process, what I think is a magnitude of indicators activity and suppressive remote signaling even the system for the underlying molecular mechanism of the neuron formation. Now, and this was tested in a study called SPRINT. In the phase 1 of this study, this was basically meant to find out what is the right dosage of selumetinib. And finally, they came up with that the middle doses, 25 milligrams per square meter body surface area, is the doses with the best result and the least side effects. And this dosage then was applied in phase 2 of the study in 50 patients with plexiform neurofibromas and with plexiform neurofibroma related morbidity. And then it was done in this continuous dosing regimen. So the result of these studies on the left side were that in the vast majority of patients, almost 2/3 of patients, you could see a partial response. Of course, no complete response. So that means the plexiform neurofibroma did not disappear, but you could see a partial response defined as a volume reduction of at least 20%. And you can see that on average, the volume reduction was about 27%, so 1/3, but there were other patients who had a much higher volume reduction of their plexiform neurofibroma, up to 55%. And on the right upper side, you can see one single patient, and you can see the bulging here in the neck caused by a plexiform neurofibroma. And after 13 cycles, one cycle is almost 1 month, so 28 days. So after 13 cycles, you can see that the clinical picture has changed dramatically. And the graph shows you that after start of therapy, the tumor volume was reduced.
And if you not only look at one patient, but see a whole group of patients, you can see here in blue, the blue lines is the development of tumor volume in the natural history cohort. So these patients were just controlled, they were not treated, and you can see that most of these blue lines are going upwards. That means the volume starting here at 0 goes up and is more than double as the baseline after a couple of years. Whereas the red lines represent the tumors that have been treated with selumetinib, and the vast majority of these lines points downward. So that means we have a significant volume reduction in the majority of the treated patients as set by the numbers in the table. Of course, it was not only volume reduction, which was in the focus. There were another couple of secondary endpoints. And you can see here, secondary endpoints might be improved ability to walk, improved ability to, or in general, improved function, less pain, improved quality of life, etc. Since this is a very individual and this is different from patient to patient, it's hard to calculate statistics on that now. But on average, you can say that the majority of treated patients reported improvements in at least one category. So it's not all about tumor, it's not only about tumor volume reduction, there are also other secondary endpoints who showed improvement under therapy. So finally, all these data led to the approval of selumetinib for treatment. And you can see that this takes a long time. And 3 years ago, in 2020, selumetinib was approved for the treatment of symptomatic inoperable plexiform neurofibromas in NF1 patients aged 2 to 18 years in the US. And 1 year later, it was approved in Europe. The only difference is that here the patients has to be at least 3 years old. So it's 3 to 18 years in Europe and 2 to 18 years in the US. So we have been treating a lot of patients. I think it's 26 or 27 patients by now with selumetinib, and that's the way we do it. Of course, before therapy, you have to have a really thorough clinical examination, and including body height and weight in order to calculate the body surface area, which is needed for a correct dosage of selumetinib. And then you have to talk a lot, you have to give a lot of information to the parents and allow time for consideration if they want the therapy or not. As a baseline investigation, we recommend a 3D MR volumetry. So a simple MRI would do as well, but as recommended by the Children's Tumor Foundation and the RAINS initiative, RAINS stands for Response Evaluation in Neurofibromatosis and Schwannomatosis. And this RAINS initiative said that a 3D MR volumetry is best to monitor therapy success. Then again, as a baseline, we do a blood analysis, we do an echocardiography and a fundoscopy. And the reason for that is that MEK inhibitor treatment is not only restricted to NF1 patients. In malignant melanoma, for instance, in adult patients, this has been used for a couple of years now. And in these patients, one has seen that one side effect might be left ventricular reduction, so an output failure of the heart, or retinal detachment and retinal edema. This so far has not been seen in children treated with selumetinib for neurofibromatosis, so it might be that they do not get these adverse events. But since we know that from adult patients with malignant melanoma, it might be a good idea to monitor that. So that being done, we start the therapy in the recommended dose, 25 milligram per square meter body surface area. And we have 2 capsules that are available at 10 milligrams and 25 milligrams. Of course, the child has been able to swallow this capsule because the suspension and fluid formulation is not yet available. And there are some recommendations about the time interval between food intake and medications that should be observed to avoid side effects. Then after 6 months of therapy, we do the first 3D MR volumetry to check for the result and check for tumor reduction. And thereafter, depending on the result, we do additional 3D MRI volumetries after another 6 to 12 months of therapy. And then on an individual basis, we ask for individual improvements, like what is the impact on pain, what is the impact on organ function, disfigurement, etc. And then we monitor potential side effects. As said before, we do monthly blood analysis and we check a complete blood count, and especially the CPK, because we have seen CPK elevations. That's typical side effect under selumetinib therapy, but it looks like it's not severe. So CPK goes up, but it doesn't have a consequence. And we do echocardiography and fundoscopy every 2 to 3 months. And there is no consensus if 2 to 3 months is the right interval, or if it has to be done even earlier, even in shorter intervals or in long intervals. That's the way we do it. Just to show you how 3D volumetry works. So this is in German, but just to show you that we have a software which allows us to calculate the volume of the tumor. And what we want to see, of course, that we have a baseline here, a volume of 101.15 milliliter. And then after half a year, almost half a year, we have a reduction of 28%. So this, of course, that's what we want to see. And here we see a good response to therapy very early. So this is the theory, our experience with selumetinib. I can show you some of the patients we have treated. And you can see that in 9 of 12 patients that we have treated, and they were eligible for MRI control, we saw a mean volume reduction of the tumor of roughly 30%. So our data corroborate the data that have been published before in the study. So this is only 9 patients, but you see this has been published in 22. And since then, we have acquired more patients. So these were the first patients we started with. And as you can see, all of them have been treated with trametinib and not selumetinib. So you might ask, why is that? This is another MEK inhibitor, which has not been tested in neurofibromatosis. But at that time, when we started this off-label therapy, it was the only one that was available. So that was the reason why we started these patients with trametinib. After selumetinib became available, almost all of these patients were switched to selumetinib, except for 2. And the 2 reasons for this is that one patient was very young. We started therapy at 3 months, and obviously a baby at the age of 3 months cannot swallow a capsule. And the other patient is old enough, but he doesn't live in Germany, and he lives in a country where selumetinib is not available. So that's why, that's the reason why he stayed on trametinib. And then we acquired a lot of new patients who were started with selumetinib right from the beginning, and you can see the numbers on the left side. So we have 24 patients on MEK inhibitor therapy. 18 of them are eligible for the first volumetry results. 2 are still on trametinib. That's the 2 patients I was talking about. 6 started on trametinib, but then were later switched to selumetinib, and 9 are on selumetinib only. And these are the results of these patients. And this graph might remind you of the graph I showed you before as part of the study, and you can see a similar picture. You see on the y-axis 0 is the volume, the baseline volume where we started, and then you see the volume change in percent. And the grayish area here between +20 and -20%, this is the area which is non-significant. So only volume changes outside this grayish area are considered to be significant. But what you can see is that the majority of lines here go first downwards, and they are outside the grayish area. So we see a good result of selumetinib treatment, and the majority of patients really had a significant tumor volume reduction. And frankly, I don't know what happened in these 2 patients. It might be a compliance problem that they just did not take the medication as prescribed. But basically, we are pretty satisfied with these results. Now, if there are good results, what about side effects? And one has to say that, yes, there are side effects. And if you look at the data from the SPRINT study, you can see that almost all patients experience some sort of adverse events. Most adverse events were skin toxicity, like dry skin, acneiform dermatitis, etc. And the second group was gastrointestinal side effects, like nausea, vomiting, and diarrhea. And we made the same experience. Our data, we had overall less side effects, but that might be a consequence of the small numbers, only 7 patients we are talking about here. But the spectrum of the side effects was basically the same. We had skin toxicity, which was the major part, and then we had stomatitis and other gastrointestinal symptoms in roughly 1/3 of the patients. We did not see any severe side effects like retinal detachment, ventricular dysfunction, etc. What we have observed, and others agree to that the age of patients with side effects is higher than the age of patients without side effects. So this is not significant, as you can see, but it might represent a certain trend that younger children better tolerate selumetinib as compared to adolescents, where we have seen the most skin toxicity. Now, you have seen that, and you have seen that selumetinib is, if you want, a causal therapy which tackles the underlying molecular defect. So if this is the case, then you have to ask, okay, what happens when MEK inhibitor therapy is discontinued? Will tumors regrow, or what do we have to expect? We made this experience in one single patient. This is a girl with a big plexuminal fibroma in the neck. We treated her with selumetinib, and you can see that after 2 years of treatment, we saw a tumor volume reduction of 36%, but due to really severe side effects, skin toxicity, we had to discontinue the therapy at this point. And then 6 months after discontinuation of therapy, we did another MRI, and we saw a certain regrowth of the tumor. So the question is, what does it mean? Does it mean that we have to continue selumetinib forever, or is there a chance that we can discontinue and stop therapy at some time point? And I noticed that you have seen this publication already, and that tells you that plexuminal fibromas grow more rapidly in younger children, especially in the age under the age of 8 years, and after that, growth velocity is decreasing. So, and taking into account these data, one could say that it's very good, or it might be a good idea to treat children at a young age, and maybe we have the chance to discontinue selumetinib treatment later on, for instance, in adolescence, when we can expect that the tumor will not grow at all. So this would be the idea, that we have a certain window, a certain time window, in which it makes sense to treat patients with selumetinib, but this does not necessarily mean that this has to go on forever. But we don't have enough data to see if this is right. Okay, I will come to an end. What do we know about MEK inhibition? So we know about plexuminal fibromas that they are present in 30 to 50% of patients, that they have a certain risk to progress to malignancy, and that they significantly contribute to the overall burden of disease and are frequently inoperable. And in that sense, the MEK inhibitor selumetinib provides the first non-surgical therapy that has been approved for these patients and has an overall response rate of 75% or a prolonged response in 66% with a mean tumor volume reduction of about 1/3. And it has a manageable safety profile with adverse events, but with tolerable adverse events. What we do not know yet is which adverse events might occur during long-term selumetinib therapy. The data we have suggest that long-term adverse events do not differ from short-term adverse events, but what will happen after 20 years or so, we just don't know. Then we do not know if it is possible to stop selumetinib therapy after a certain time. I've told you that there are some ideas that this could be an option, but we don't know it yet for sure. What we don't know either is if selumetinib can be combined, and if it is a good idea to combine it with other anti-tumor therapies to improve the results. And since selumetinib addresses the molecular basis of not only of neurofibroma formation, but also of the disease itself, we do not know if selumetinib can be used to treat other manifestations of NF1, like optic pathway gliomas or like cognitive problems. Might be possible, but we don't know it yet. What we know, and this is the new thing, is that by now we have 3 different therapy options for plexiform neurofibromas. We can, as we did in many cases in the past, we can just do nothing, watch and wait. In that case, we do not have any surgical risk, but progressive symptoms might evolve over the years, and the optimal time point for a therapy might be missed. Then we can do surgery, which is good because you have an immediate success if a complete resection is possible. But as you heard, very often a complete resection is not possible and has a lot of intra and post-operative risks like bleeding, morbidity, and so on. And we do not know for sure if operation of a plexiform neurofibroma might stimulate the remaining tumor tissue because it's the operation itself is some sort of mechanical irritation. But we don't know that for sure. Now that is on debate now. And then the new therapy is MEK inhibition. There you obviously do not have any surgical risk. You get a reliable tumor shrinkage, an improvement of symptoms, maybe even a prevention of upcoming symptoms. But you need some time. Therapy effect is visible only after several months of therapy, on average after 8 months. You do have adverse events. We don't know what about long-term adverse events. We don't know how long the therapy has to be done. And we thought in the past that MEK inhibition in plexiform neurofibromas might also prevent malignant transformation. But it looks like that this is not the case because there have been 2 case reports out that plexiform neurofibroma turned malignant while under MEK inhibition. So this, we have to say it's not reliable. So we don't know if we really can prevent malignant transformation. Okay, this was my last slide. I hope I was clear. Thank you for your attention.
Thank you, Professor Rosenbaum, for an exhaustive and a wonderful talk. Can we request you to stay on for the panel that you want to, if you
Yes.
can, then, I'll invite the panelists. You can just add on being a subject expert in that, in anything. So I would request Professor Madhulika Kabra, Professor Somesh Gupta. Professor Madhulika Kabra is Head of Genetics, Department of Pediatrics, All India Institute of Medical Sciences. Professor Somesh Gupta, Professor of Dermatology. Dr. Rachna Sehgal, she's Professor of Pediatrics, Vardhman Medical College, Safdarjung Hospital, an alumnus from here. And her batchmate only in the DM, Dr. Bishrup Chakravarti, would be moderating the panel. Dr. Bishru, I've requested Dr. Lokesh, can you also be there? If you can ask Dr. Rosenbaum and Dr. Lokesh can come here. Yeah. Please come. Okay. Yeah, the WARDI team wants to welcome you. And please. लगा दो इधर। हाँ। After the panel? No, okay. Mr. Samir Sethi is President of Indian Rett Syndrome Foundation. Thank you, Mr. Sami. Vishnu will just start. Can
Yeah,
we have the
start,
slide?
yeah. So I'm already.
Good afternoon, everyone. Thank you, ma'am, and thank you, the organizers, for this wonderful opportunity. So next half an hour or so, we will actually revise whatever we have gone through in last 1 hour. So all the exhaustive talks, we'll just be revising and touching upon these points only. So I'll start with the first question. This will basically be an overview on neurofibromatosis. So this is for Dr. Rachana. So Dr. Rachana, how common is neurofibromatosis?
So, Dr. Vishwarup, actually, if we say that this is not very common, that will be wrong because the prevalence globally from various registries has been found to be as high as 1 in 2,500 to 1 in 3,000. From India, we do not have actually registries, but we have some clinical epidemiological studies where they put the estimate to be somewhere in similar 1 in 2,500 to 1 in 4,000. So this is for NF1. This, which is the most common variant of the neurofibromatosis. The other variants like schwannomatosis associated with the NF2 and the ones which are schwannomatosis associated with other variants other than NF2 are not so common. But yes, NF1 is commoner. Yeah.
Just to add on to that, for all the panelists, do we have any registry in India at this point of time, any hospital-based data or any community-based data for NF at this point of time? You can take that, ma'am.
So in the rare disease registry of ICMR, NF is not included. I mean, doesn't really come under rare disorders, but because the frequency is almost like thalassemia, which is 1 in 2,500. But there are some Indian reports available on some cases, and for one of our DM students also, we had a clinical details and some data on the deletions which are there in NF. So about 70 patients we had. And in that we have collated the data, but not yet published. But I'm not sure if there is any registry which is going on in India for NF. Maybe in times to come, because the number of patients is huge. We should
Yes,
probably
ma'am.
come out.
Yes, ma'am. This question is for you only, ma'am. So what is the basic pathogenesis behind neurofibromatosis?
So we heard this in multiple talks. So we know that this is because of the variations in the NF1 gene, which is neurofibromin. And this actually comes in the multiple pathways which are involved with tumor formation. So it is a tumor suppressor gene. And because of the variations in this particular gene, you have various manifestations. It is not really clear that why such varied manifestations do occur, though the pathogenesis is explainable with this pathway. And the complete penetrance with variable expression is a very, very important feature. So you may have in the same family, you may have individuals who have very mild manifestations, whereas in the offsprings, you may have very severe manifestations. So this is a feature of all autosomal dominant disorders, which is also seen in neurofibromatosis.
So before going on to the next question will primarily be focusing on the clinical manifestations. So in the panel, we have tried to divide it into 3 categories. So one would be the cutaneous manifestations. This would be followed by the neurological, and then we'll be covering the systemic manifestations. Somesh sir, this is for you. So what are the various skin manifestations of NF1?
Yeah, so when often these children and the adult patients, they come with, they present primarily with skin manifestations before they develop other systemic involvement. So the initial manifestations are very subtle and often considered insignificant, and unless we have the high degree of suspicion, we miss on those. So the most common is, like most significant, is cafeole macules. Yeah, these cafeole macules are brownish pigmented macules of coffee color. That's why they are known as cafeole macules. Not in brownish or Indian skin, they don't look like exactly coffee color, but they are just hyperpigmented, well-defined macular lesions. Now, in children, they have to be more than 6 or more of at least 0.5 centimeter size. if they are there, it is almost confirmatory of neurofibromatosis. The other thing is that we have those axillary freckling, which is again very, very diagnostic of neurofibromatosis. And what happens sometimes, if this is just a spontaneous mutation and no family history, still we can make a diagnosis of neurofibromatosis in the absence of multiple neurofibromas. So when children don't come with multiple neurofibroma, they come only later in the life. But when we examine carefully, we often detect one or two early neurofibroma which are present. These neurofibromas are very soft, even though they are supposedly fibrous tissue, but they are very soft in consistency. And those nodular lesions, when we press them, they disappear in the skin. So this is a diagnostic sign for neurofibroma. And apart from that, there are multiple tiny neurofibromas which are also seen. And as the age, as the person get aged, we get the whole body studded with neurofibroma. In fact, there was one patient who was admitted with us. He had no skin left without neurofibroma, and he had extremely intensive itching that disturbed his whole life. So we had to give naltrexone to him to control the itching. Then apart from the most disfiguring and the most pre-malignant lesion is plexiform neurofibroma, as you see on the face of this lady. So this is really difficult to treat. We do surgeries, but we don't do in children. But in adult patients who come with plexiform neurofibroma, we do cosmetic correction surgery by removing the bulk of it. It is rarely possible to remove the whole thing, but at least when the bulk of it is removed, most patients are satisfied.
Thank you, sir. This is for you, Dr. Rachana. So what are the neurological manifestations of NF1?
So as we know, this is a neurocutaneous syndrome. So after the cutaneous manifestations, neurological manifestations are also very important. And actually, Shefali ma'am has covered almost all of it. Just to recapitulate and reinforce, I will say that the most common neuropsychological component of the manifestation is the cognitive impairment. Most of the time, the IQ is in the low average range. It is not that the child will have intellectual disability per se, but mostly it is just a low average kind of IQ. And also specific learning disabilities are very common, especially dyslexia and dysgraphia, they are very common. Then they have also problems with visual spatial orientation. Then autism and attention deficit hyperactivity disorder, especially the inattentive and the combined phenotypes, they are common. Epilepsy is not very common, but whenever it is present, usually the focal seizures secondary to the hematomas may be present. And sometimes the catastrophic epilepsy types like the West syndrome and Lennox-Gastaut syndrome may also be present. Large head size is a common manifestation, and that is because of the associated megalencephaly. Then cerebrovascular disease is also there. The worst component is the Moyamoya disease, which will present with recurrent strokes, which could be ischemic, which could be hemorrhagic. But sometimes we just see the aneurysms and sometimes the stenosis or occlusion of some part of the cerebral vasculature. Then peripheral neuropathy. It is usually a sensory motor polyneuropathy, and usually it's a very painful kind of neuropathy. So since this peripheral neuropathy is because of the neurofibromas, which have a tendency to even have a malignant conversion, so it has to be really managed well. Then headaches. Headaches are either because of the hydrocephalus, which is there in 5 to 15% of the patients. And these are usually because of the aqueductal stenosis, webs, and sometimes it may be even because of the brainstem gliomas, which are diffusely infiltrating. So sometimes they may be associated with other problems like gait instability or cranial nerve, multiple cranial neuropathies. Then the tumors is the most debilitating aspects. Although the optic nerve gliomas are more common in the children, usually seen less than 6 years of age, and these usually present with vision impairment. Sometimes diplopia may be there, and sometimes if it is involving the optic chiasma, then field defects, and even precocious puberty if it is infiltrating or causing pressure over the hypothalamus is seen. Then the other worrisomes are all types of astrocytomas, pilocytic, even glioblastoma multiforme, although less common, but it is there, diffuse infiltrating astrocytoma. All kind of these gliomas and astrocytomas are seen to be associated with neurofibromatosis.
Sachna, I am just barging in between. Dr. Lokesh, I just wanted to ask you that do you have this protocol of seeing all patients with NF holistically with the neurodevelopmental issues? Because I think we need to have, like you see for TAND and TS, that is very standard. I think we have to ensure that like TAND, we should have neurodevelopmental evaluation in all these patients with NF. Dr. Lokesh? Dr. Rosenbaum, I think there you must be having standardized protocols to holistically evaluate, right?
Yes, but basically we do it in the same way as pointed out. So we really check for the development of the children, because we know that we have a very high percentage of developmentally handicapped children with issues in that field.
Actually, there has been paucity of data. So we are developing a registry which we'll be soon launching, which is going to cover all neurological and neurodevelopmental disorders, and neuroectodermatosis is a part of it. And that is going to have a unique feature is that it's going to account for all the comorbidities, and that's why it's taken so long. And it will also be a dynamic one, having a follow-up. It's not a cross-sectional one. So I mean, that will help us to understand which kind of patient population is where for any future trials and all in the future. Vishnu, please continue.
Thank you, ma'am. This is for Madhulika, ma'am. So, ma'am, what are the other systemic findings that are seen in NF1?
Yeah, Vishrup. So it has already been discussed already. So lesion nodules, tumors of various types other than the CNS tumors can also be there. Skeletal abnormalities can be there, and many of these patients present with pseudoarthrosis, scoliosis, other vertebral defects. Short stature is another prominent feature in these patients, and there are some mechanisms known, and out of which growth hormone deficiency is one of the mechanism. And if there is a supracellular lesion, then it can explain growth hormone deficiency. Or there is, because probably this protein also acts on the hypothalamic pituitary axis and regulates that. So in patients who have growth hormone deficiency in NF can be treated with growth hormone therapy, and the results have been good. Rarely you can have congenital heart diseases, hypertension, and other manifestations like constipation. So just to add on I was telling you that in Dr. Ravnee's thesis, we had 70 patients. So in those, of course, the dermal manifestation, 70% had Caffiole spots, and cutaneous neurofibromas in about 50% of patients. And out of these, about 45% were plexiform neurofibromas. Lesion nodules in about 75%, pseudoarthrosis they presented within about 12%, and short stature in about 25% of patients. And at presentation, 8 patients had tumors, totally, out of which 4 were optic gliomas, pilocytic astrocytoma in 2, quadrigeminal cistern lipoma in 1, and CV junction and cerebellar hemangioblastoma in 1. So this kind of data is available, which is almost comparable with the literature.
Thank you, ma'am. So just to summarize, which already has been covered by Dr. Lokesh. So what is the current diagnostic criteria? So one is involvement of 6 or more Caffiole macules, which already Somesh sir has highlighted, more than 5 millimeter in prepubertal and more than 15 millimeter in postpubertal. And for each lesion, the longest diameter is measured. Then we have 2 or more neurofibromas or any type, or 1 plexiform neurofibroma. Then we have axillary or inguinal freckling, optic pathway glioma, lesion nodules or 2 or more choroidal abnormalities, a distinctive bony lesions like sphenoid dysplasia, bowing of tibia or long bone pseudoarthrosis, and the heterozygous pathogenic NF1 variant with variant allele fraction of 50% in apparently normal tissues. So all these are there. So greater than equal to 2 is required in no affected parent, and greater than equal to 1 if one parent is affected. So this is the current diagnostic criteria. So moving on to the next question, Madhulika ma'am, this is for you. What is the role of genetic testing in NF?
Yeah. So as you all understand the diagnosis is clinical, particularly in the older age group, when the manifestations are there and you are able to fulfill the clinical criteria and make a diagnosis. So one could be a doubtful clinical scenario. We have had few families where there are few Caffioli spots or only Caffioli spots, which are 6, 7, 8 in number, and there is nothing else with or without a family history. So in this situation, it would be important to have. So in about 95% of cases, a molecular diagnosis is possible, which includes sequencing of the NF1 gene, along with, if that is negative, you can have deletion duplication studies, which is MLPA, and that is reported to be there in about 5 to 75% of cases. And again, in Ravni's thesis, we found it in about 12-13% of cases. And the other issue is that it will particularly be important if the family is desiring prenatal diagnosis in the subsequent pregnancies, because without a molecular diagnosis, we will not be able to do that. Apart from that, though there are phenotype-genotype correlations known, it is not very robust. I mean, it is not uniform, but we do have, as it is written here, that few of the variations have a milder phenotype, and then some of the variations have more severe phenotype, and like Noonan-like phenotype, which is very, very interesting. So in some of the NF patients with NF mutations only, NF1 mutations only, you have Noonan-like phenotype. It has been suggested in literature that large deletions have severe neurodevelopmental problems or a severe phenotype, according to literature. But again, in the work which was done, we did not have a difference. But then the comparative number, in the two groups, the numbers were sort of not similar to do that comparison. So it is important for confirmation of diagnosis, prenatal testing, and in doubtful cases, definitely. And in situations where we are doing the tests early, or if we want to do a phenotype-genotype correlation, which is, I mean, in the early stages of the disease, that may be important.
Thank you, ma'am. So this is again for you, Dr. Rachna. So what are the characteristic neuroimaging findings in neurofibromatosis? You want me to show the scans? Okay.
So actually, what earlier were known as unidentified bright objects and now known as focal areas of signal hyperintensities. So on the first picture, what we can see is that in the middle, this one you are pointing, so I'll just point this. So
Or you
there are,
want this one?
yeah.
Okay.
So in the middle cerebral peduncle along the dentate nucleus, so these are unidentified bright objects or focal areas of signal hyperintensities, which can be seen. Similarly, on the left side, we have this in the basal ganglia, then in the frontal white matter, and in the parieto-occipital white matter. So any areas we can have these signal hyperintensities. In fact, they may represent either hematomas or abnormal myelination or gliosis. Whether they have some association with neurocognitive deficits is very controversial. But yes, they are prone to have malignant transformation. That is why we need to annually screen them with a neuroimaging, especially if there is any deterioration in the clinical features. The next one also.
Yeah.
So yes, here we can see in the midbrain, both in the tectum as well as the tegmentum. In the crus cerebri, we can see the same signals, hyperintensities. And in this, just below the optic tract, in the optic chiasma region, we can see that the left part of the optic chiasma, yes, just below that, yes. So that is enlarged. So even if there is not a very diffuse or homogeneous involvement of the optic chiasma, sometimes you can even see unilateral optic chiasmal involvement, which may be picked up clinically on field perimetry, and radiologically, yes, we can pick it up. So this one was just to highlight that we need to look at the inferior orbital walls, and especially to look for any sphenoid wing dysplasias. So in this case, we can see that there is no proptosis, and even the eye globes are positioned equally. But sometimes we can see that the eye globe is positioned anteriorly, and there may be missing of the inferior orbital wall, which is because of the sphenoid wing dysplasia. So even that finding can be picked up when we are doing a routine MRI. Sometimes we see megalencephaly, and sometimes we see the cerebrovascular anomalies like MRA. On MRA, we can see the moya syndrome.
Okay. So now moving on to management. So the main components of management are, as has been highlighted by everybody till now, it's a multidisciplinary care. So, you know, lots of specialists, lots of rehabilitation people are involved in managing a child with neurofibromatosis, and routine surveillance is very important. clinical surveillance is the cornerstone. And then based on the clinical findings, the individualized way we look at investigations in each of these patients. So Madhulika ma'am, what is the current recommendation for annual pediatric surveillance? This is by the American Academy of Pediatrics and the American College of Medical Genetics and Genomics. This is their guideline.
Yeah, before we go, there's a question on the online, which is related to MRI. That's why I just barged in between because I thought it was relevant. The question is, what are your views on the role of whole body MRI, like in the Korean study? In the Korean study, which is published in Orphanet Journal of Rare Diseases, 2022, in which whole body MRI evaluation in NF type 1 patients younger than 3 years was done and genetic contribution to disease progression was seen. So basically, there's a whole body MRI working group which has worked. I mean, try to arrive at a consensus for NF1, and they have just in their publication they have said that currently there is no evidence enough so to recommend that whole body MRI should be done in all children less than 3 years as of now and periodically. That is a guideline for that answer. And the next question which is there will be in management. So I'll barge in that time.
Sure, sure. Yes.
So these are all written here. So these are for all forms of neurofibroma. So annual surveillance, neurological evaluation, and MRI brain. If there are manifestations like seizures and focal deficits, hypertension has to be looked for. That's very important because the cause can be both pheochromocytoma and renal artery stenosis. Measurements, particularly for head size as they grow, because macrocephaly can be a problem and it can be because of a pathological reason. Skeletal changes to look for, again, routine x-rays are not recommended, eye evaluation, and if there are any manifestations, then we can have a detailed ophthalmological examination, precocious puberty to be looked for. And additionally, as it has been emphasized, a significant proportion of these patients have behavioral and other issues. So this has to be carefully looked at because this can be easily missed, particularly if they are subtle or if they are very mild. So it is important.
Yeah, Somesh sir, this is for you. So what is the recommendation for annual adult surveillance in those who have neurofibromatosis?
Yeah, so the most significant one is, of course, the malignant transformation, and this is more in plexiform neurofibroma than in other kind of neurofibroma lesions. So when plexiform neurofibroma, they become hard in consistency. They are generally very soft. Soft is as much soft as if cystic lesions. So if they become hard or ulcerated, or they suddenly grow in the size, then that's a sign of a malignant transformation. So all patients should be educated about this probability. And in the previous talk, it was shown that it is not so uncommon. So we have to be very careful. Apart from that, there are other cancers like breast cancer is there, then hypertension, as you mentioned here, and we have to look for pheochromocytoma and renal artery stenosis. And pheochromocytoma screening from 30 years, as you mentioned, but earlier if pregnancy and with hypertension the patient presents. And then osteoporosis and scoliosis, these are generally clinically obvious when we have to be vigilant about it. And then neurocognitive and psychiatric manifestations already discussed in detail, reproductive issues and high risk obstetric care and chronic pain. So these are the things which are recommended for annual adult surveillance.
So the important point is whether it's a pediatric patient or an adult we are dealing with, annual surveillance, multi-system surveillance is of utmost importance for routine care of these patients. So this is again for you, sir. How are neurofibromas managed?
Yeah, so these patients, they go from center to center without getting any help. I think most people are not interested, most doctors are not interested in taking care of them. One is that this is an uncommon disease, even though ma'am said that it is quite common, not so common in the routine. So many doctors are not trained for management of these skin lesions, but we routinely provide care to them. And often the reason for presentation to us is cosmetic in the early stage, particularly in the early stage of life, because these lesions, if they are present on the visible areas, they are associated with a lot of psychosocial distress and impairment in the quality of life. So we do excisions, and the recurrence rate of, even if the incomplete excision, recurrence rate is relatively low. So we remove them for cosmetic reason, or if some lesions become painful. And invariably the plexiform neurofibroma patients, if they are present on the face or even on the trunk, they come to us for removal. So we do staged excision, serial excision. We cannot remove the whole thing in one go, but most patients are benefited out of it, and many of them are satisfied. One thing I want to highlight here is that these are highly vascular, so much vascular that sometimes we have a feeling as if they are vascular malformation and not just neurofibroma. So the excision has to be done with care. Otherwise, post-operative complications such as hemorrhages and hematoma formation is a real risk in these patients. So the commonest indication is disfigurement. And laser removal is mentioned here, but it is often very difficult to remove with laser because it creates a lot of smoke, secondary intention healing, and resulting scarring. Electrodesiccation or electrosurgical removal is still possible because we can remove them from the base and suture them. So these are the things. But as I mentioned that sometimes we have patients who have intractable pruritus, and these patients are generally benefited with from gabapentin or the whole body phototherapy at times, because routine antihistaminic drugs, they do not work in these patients.
Thank you, sir. We have already had a wonderful lecture on management of plexiform neurofibroma and role of selumetinib. So we'll move on to the next question. So Dr. Rachita, how are neurological manifestations managed?
So the most common neurological manifestations of concern are the tumors, the gliomas. So optic nerve gliomas, first we have to pick them up by the annual surveillance and being not only radiologically, but also clinically with the annual visual exam. Then if they're picked up, then they are very chemosensitive. And the drugs which are usually used are vincristine and carboplatin, and sometimes vinblastine also. The important thing is that unless it's a very high grade gliomas, we do not really advise them to go in for radiotherapy, because radiotherapy is associated with lots of high chance of secondary carcinomas. Secondary malignancy rate is very much high with that. So only if there is high grade gliomas or malignant peripheral nerve sheath tumor after surgical excision, one might ask them to go in for radiation. The rest of the things like intellectual disabilities, specific learning disabilities, autism, ADHD, they are managed as we do for the rest of the general population.
Here's a question online, which is related here. How do you manage a 4-year-old with confirmed NF1 with severe disruptive, oppositional, and hyperactive behaviors, no focal neurological deficit, and MRI brain not done yet? You want to take it?
So actually, for oppositional defiant disorders, sometimes we can give drugs like risperidone. And for the hyperactivity component, both atomoxetine and methylphenidate, depending on the age, as well as the
4
behavioral
years.
therapies.
4 years.
4 years. So 4 years, we will not go in for methylphenidate. First, we will try for the behavioral therapy, the occupational therapy. If that can control the hyperactivity, that is good. And if it is not, even after 6 months of good occupational therapy, if the hyperactivity is not controlled, we might consider the drug management. And at the same time, we will like to get one MRI brain done.
Yes,
Yeah.
I would like to get an MRI brain done, definitely. Dr. Rosenbaum, Dr. Lokesh, want to add something?
We would do it exactly the same way, exactly. So no differences.
Okay, thank you. But we'll ask for an MRI, right? I would like to do
Yes,
that. I
yeah.
would like to do. Thanks. Vishnu, please. Continue.
Okay, Madhulika ma'am, so how are other systemic manifestations managed?
So, as discussed earlier, there can be bone abnormalities. So surgical interventions may be required if there are severe bone deformities, and other rehabilitative measures for these orthopedic problems. And for all chronic diseases and otherwise, also vitamin D deficiency is a common problem. So you have to look for that. There are no clear guidelines about use of bisphosphonates. If there is severe osteopenia, and DEXA indicates that there is, which is very low in that situation maybe, but I'm not really sure whether they're routinely recommended. Short stature, we have already discussed. If there is growth hormone deficiency documented, then growth hormone can be used, and we discussed the reasons for growth hormone therapy. And there was a concern with growth hormone therapy that they can develop tumors, but then there are studies which say that that's not a major issue. I mean, this can be given. And for hypertension, management depending on what is the cause, whether it is renovascular or it is pheochromocytoma.
Thank you, ma'am. So, ma'am, what is the risk of recurrence in future pregnancy? Because this will be a very common question once parents come to know that this is a genetic disorder.
Yeah, right. So we understand it's autosomal dominant disorder. And if it is familial, which in again our set of patients, in about 40% of patients it was familial and 60% it was a new mutation. So the risk of recurrence is going to be 50%, as you have the rule in autosomal dominant disorders. There are segmental disease also, which we did not discuss, which is due to mosaicism, and here the risk of recurrence is low. But then if neither of the parent is having any clinical manifestations, because the penetration is significant, it's very unlikely the parents will not have any manifestations and will have the disease. So the risk of recurrence would be low, 1%, around 1%, 1 to 2%. And this is because of germline mosaicism, which either of the parent might be carrying the abnormal gene, the mutation in their gonads, not in the, we cannot detect in the genomic DNA. So 50% risk of recurrence, and many of our families would undertake prenatal testing because of the severity of the disorder, the disfigurement and other associated comorbidities.
Thank you, ma'am. Dr. Rachana, so what is the long-term prognosis and what are the determinants of this prognosis?
So, Vishwaroop, as we know that because of the propensity for malignancies, so survival may be slightly limited, but still most of the people do reach their 5th and 6th decade. And depending on the type of cancer and its detection rate and its management, the survival rates may differ. In the children, if they are detected and they are low grade, then survival is not really affected. So only the malignant transformation is the one which causes limitation.
Thank you. So Shefali ma'am, you can have the concluding remarks. We're done with the panel. Thanks to all the panelists.
Our expert on
definitely,
oral therapy, Dr. Rosenthal.
Yeah, definitely.
So I just wanted to ask, is there a role of combined therapy like surgery plus selumetinib?
Well, might be. We had made the experience in one single patient where operation on the cervical spine had to be done, but the whole neck was full of plexofemoral fibroma, so it was very hard for the surgeon to reach the cervical spine. And in that patient, we initiated selumetinib therapy for about 6 months, which led to a tumor reduction of about 30%. And then it was easier for the surgeon to do the spine operation. So there might be a role to combine these things now.
Okay. Right. Thank you very much.
I think then we just have to understand that we have to see every child comprehensively, holistically, and their parents, and follow them up. Surveillance is important. And we have to understand that, up more than 50% may have ADHD, up to, 1/3, beyond more than 1/3 can have autism. So, and so many of them can have SLD. So there's so many issues to be seen and tackled. So I think you need a multidisciplinary approach. So I think probably where we are working in silos, so probably here is an importance that we should start establishing, under one roof, having a pediatric neurologist, a geneticist, and a dermatologist, and all sitting together to see which we are trying. We tried and have failed miserably many times. But I think we'll have to do that. And that even if we do periodically, doesn't have to be that frequent, because then the patients can come that point of time and they don't have to come again and again, and we can see the child holistically. I think something like that, Mr. Prasanna, we are planning to do that. We will do that for this, and that situation may help all these patients. And probably when we launch the registry, then we will let it be known, and whoever wants to do will be able to join the registry. I think we have to understand that, and that is about it. And new drugs which are coming up will have to be tried, but they are very expensive. Dr. Rosenbaum, I would like you to give one final message from your side. And I will
Well,
tell you
first of
that
all-
participants are not only in India. Online participants are from Malaysia, Bangladesh, Nepal, Sri Lanka, and Pakistan as well. So I think so it will be going to many more. Yeah, please.
So first of all, I would like to thank you for having me and for giving me the opportunity to present my talk. I think it was an excellent meeting. I have learned a lot, and I see that you really have a comprehensive care for neurofibromatosis patients. So thank you.
Thank you, Dr. Rosenbaum. Lokesh, are you still on there? Madhulika ma'am?
I would like to thank Mr. Prasanna, Shefali, Visru, and the whole team for involving me in this very interesting session. And as Shefali said, we would like to have a multidisciplinary clinic for these patients, for that matter, for all of the patients with neurocutaneous syndrome. So would like to help them, and we'll plan something like that very soon. So thank you very much. I really enjoyed the session. Thank you.
Dr. Somesh?
Yeah,
Or
thank
online,
you. It was
master
very,
for
very
this
informative,
message.
and
Online.
I think this brings focus on a disease which nobody talks about. It's even though it's not so rare, it is an orphan disease, and these patients are not helped actively by many institutions. So I think this whole program brings back the focus on a disease where we need it. Yeah, thank you.
Thank you, Dr. Sumesh. What you said was very right, but only thing is you've touched one thing which I always refute everywhere. I say we should stop using the word orphan. I mean, orphan is not a good word to be used. No, what you said was absolutely right. I'm just saying that we have to understand that the whole fraternity has to stop using. Even the industry has to stop neglecting. Everybody has to work, and you have to see that they need more special attention. That is all. Lokesh, are you there before I ask Rachna?
Yeah.
Please. Yeah. Hi. Yeah. Your last some message.
Yeah. Yes.
We missed you.
Actually-
You were supposed to fly to Delhi, but we
Yeah, I
missed
know.
you. Yes.
Yeah. Sure. So I think these are the situations with such multifaceted presentation. Although plexiform neurofibroma is one part of the presentation, and they also have significant optic pathway gliomas are very recalcitrant to treat. So if you have something to manage them as well, it will be wonderful, because that gives such a long-term morbidities. And although the other problems like intellectual disabilities and moya, those are all multiple things. But having a collaborative data from the whole of the country, I think we need to take a lead and then try and have it, so that there is a ready available database for any new drug that is being discovered. People want to know what is the database, where is the patient, and where can we reach them. I think we should start with that, having a database countrywide. That will be a good contribution with the start of this program. Thank you.
Absolutely, Lokesh. Actually, you must be feeling we've been talking for long for the registry, but there
Yeah.
were many nuances which came up. We were making
Yeah.
actually 16 different registries, and then we decided to combine into one. So I
Okay.
think maybe 2-3 months we should be out with it.
Sure,
So then
sure.
we can have a part of it. Thank you so
Sure.
much.
Thank you. Thank you.
Thank you so much. And Rachna.
Thank you, ma'am. It has been a great learning experience for me. And I would just want to reiterate the same fact that these children do require a multidisciplinary management. And what sir said, that cosmetic effects, they are very important. In fact, one of my patients, he wears the full sleeve shirt, even in it is June or July, because of the plexiform neurofibroma that he has over the arm, entire arm. So this is something we kind of miss, that he may be having a psychological
Absolutely,
because of that.
absolutely. I mean, it is very important. Cosmetic is not only cosmetic, it is actually, it is a health, what is the child feeling, what is the person feeling, and also inclusion in society, the way, actually, one, maybe this is not the forum, but always it's a forum. Any problem, the attitude of the people around you makes a lot of difference. Make a lot of difference in this, anything. So if you have a condition that actually becomes a disability because of your environment may be both physical, when you have physical challenges and you don't have those or, for your vision and hearing you don't have, but the other is the people around you. The negative people around you also is going to hamper your progress, and it's going to make it disabling, even if it was not a disability. Vishnu?
So thank you again. So I think everything has been talked about. So just one important point, that it has to be always a teamwork. So health workers, parents, family, advocacy groups, support groups. So everybody has to come together, in management of these children. Thank you so much.
Thank you. And we will be, Mr. Prasanna has already, we recorded the session, we'll be putting it on YouTube, and we'll be sharing the link of the program. I understand Dr. Rosenbaum's initial 10 minutes was not clear to international participants, but then it was all right. So we'll be sending the recording one to all of them anyway. Thank you. Mr. Prasanna will have the vote of thanks in concluding remarks.
Good evening once again. Whenever we conduct these programs, we always think that we'll find some solution. But at the same time, we always have a questions or a homework for the next. Looks like it is a never ending. There is always a next post, next target which we need to. So today, the first is we have a hope. Always, in rare disease, we talk about a hope because all of us parents live only on hope. That is the only medicine, the first medicine. And fortunately, I would like to take the opportunity to announce on behalf of the company that AstraZeneca, who has acquired a company called Alexion, they are bringing the range of rare disease medicine. And the first one, they are launching drug for neurofibromatosis, probably next month in the June, should be available for Indian patient. I think this is a great moment for me, where we have started observing a particular disease condition and awareness day, and also a good news that a drug is available for Indian patient. But the next question is the affordability. I think Dr. Madhulika ma'am comes into picture here with two questions. How do we get access to the patient? And also she mentioned about that this may not come under the rare disease, which is again another target for us to what exactly mean the rare disease in absence of a definitive rare disease definition in India and also in the policy. That is a new question which we need to find answer. And I'm sure Dr. Madhulika Kabra will help us as usual. So I take the opportunity to thank first Dr. Shefali madam on behalf of AOCN in a short notice when she was flying abroad, and I called up at the night 9 o'clock. And she said, yes, we'll do it. And even I was also out for almost a week. And fortunately, this program helped us. And thank you, ma'am, for collaborating and associating with us to have this wonderful opportunity to talk about the new condition in India. Also like to thank Dr. Mahesh Kamte and Dr. Lokesh Lingappa initially, who put this entire thing together. Then as a speaker, also like to thank Dr. Lokesh Lingappa. We could not have him here physically. We miss him. We miss you, sir, definitely, and look forward again in future. And also like to thank international speaker, Dr. Rosenbaum, for giving us an overview from the international, and also we had an opportunity to learn both from Indian medical fraternity and international. Thank you, sir. Thanks for your presence. And also our panelists, Dr. Madhulika Kabra, Dr. Biswaroop Chakrabarti, then Dr. Rachna Saigal, Dr. Somesh Gupta, for enlightening us and answering all those questions. I think panel is one of the most important session, which gives answers and many of the questions for us as a parent also. And as we are going to keep this recorded on a YouTube live, and should be available to all those who are not able to attend today. And people who have attended virtually and physically also, I'd like to thank, and apologies for initially delaying the program for a bit. Then finally, I would like to thank AstraZeneca team, Dr. Apeksha and Dr. Lokesh, for supporting us to organize this event and managing certain logistic issues. And I'd like to thank Mr. Samir Sethi, who represented as a ORDI PAG Advocacy Chairman for this occasion today, and also our event organizer, Priyanka and team, and Kalki Events for organizing all the digital media and support. finally, my ORDA team, Mr. Madan and Chetna, who are in Bangalore and did their work to make this happen. And I think it is an end. Looks like it is again a hope, wonderful program, and look forward to all your support, making these dreams of treatment realized to Indian patient, and support from all the medical fraternity. Thank you so much.
Thank you. Thank you. Dr. Rosenbaum, please don't sign off. We'll have you on the screen and have a group photograph here. Dr. Rosenbaum? You still
Yes,
there?
I'm
Yeah,
here.
yeah. If you just come in front of the screen and we'll have a photograph, please come. Also, thank you. Dr. Lingappa cannot come on the same screen because these are on different rooms. I found out. Dr. Lokesh, you stay on. We'll have you again on the screen and take the.
Yeah, I'm on.
Dr. Rosenbaum is through another link because our current link will work out. Dr. Samir? Dr. Samir will get it, don't worry. And Samir ji, please आइए. What? वो मोहन छोड़ो. विषय कीजिए ना. Second, Puneet and Kaushik. क्योंकि आज अरविंद और दुष्यंत सारा काम तो बिहाइंड द सीन पुनीत करते आज इधर आप मिल रहे अरविंद so we can come आगे आ जाओ. You better click it well with eyes open. Yeah, you just that. सर वो AI बेस्ड में डाल देना consent not given. Thank you. अभी wait करो आप लोग. लोकेश का डालो please. Thank you, Dr. Rosenbaum. Thank you so much. It was a great pleasure to have you. Thank you so much. Amy जाना नहीं ma'am.
Thank you.
इधर आओ लोकेश को पूरा एक स्क्रीन पे करो ना फुल में हमें वो ग्रुप नहीं चाहिए ना सिर्फ लोकेश फुल स्क्रीन में दीजिए राइट अभी लोकेश इज लाइक अ गॉडफादर
Don.
अभी लाइट अभी ठीक है Thank you. That's a
Thank you.
background, right?
Thank you.
Thank you so much. Thank you, Dr. Rosenbaum. Thank you, Lokesh, and thank you all the online participants.
Yeah, thank you very much.
Thank you so much. Thanks. Laptop किसका है? एक मिनट रुको. हाँ तो delete.